Okay, now we're going to talk about Trisha. She has 17 years of experience in obstetrics and gynecology. That is such a hard word to say. I don't know how you guys do it every day. She's super passionate about empowering women. I am personally a patient at Iowa Women's Health Center, and somebody said to me earlier today, like, are you aging backwards? And I'm like, yes. And they're very helpful in making that happen for me, and making me feel a lot better in my own skin, and making me feel like I'm not losing my mind. And when I am losing my mind, and handling it in a way that I don't completely, what the kids say, crash out. Anyway, so I am personally a huge fan of Iowa Women's Health Center, and love that they are taking women's health in aging in a way. I think they're just doing it in a way that I've never heard of before, my mother never heard of before, and my grandmother never heard of before. They told me to just live with whatever I was dealing with, and I don't want to. I'm not interested. So she's super passionate about empowering women, and takes comfort, respect, and minimizing unnecessary pain very seriously. And if you've ever experienced any sort of trauma in gynecology, you know that that is not what all of the professionals are out there doing. So I love that they are making a huge wave in that medical space. She's also a Packer fan, which I love. And she's going to talk to us about, oh my gosh, now I've lost your, hold. No shame. Oh, great. Okay, so the title of her talk is An Integrative and Trauma-Informed Approach to Women's Health. So welcome to the stage, and thank you for your grace.
I might need the 10-year-old's stool, but we'll see how this goes here. So hey, I'm the introvert that's always in the back of the room, and never up here, so I'm not really sure what I'm going to say exactly. We'll get through it together, though. Is this my clicker? Yes, it is our clicker. Okay, so here's our clinical team at Iowa Women's Health Center. Iowa Men's Health Center as well. We do help the guys out a little bit with hormone therapy also. Address, phone number, webpage if you want to check us out on there. We do have some information too over on the table if you need to grab it on your way out. So Google, the interwebs, if you Google what gynecology care is, this is what they say that we do. And we do all of these things, but we actually do a lot more than that, and I think that's a common misconception in healthcare and when patients are trying to find a provider to help with concerns they have. This is pretty basic, pretty old school list here. At our clinic, we do a lot of traditional / modern medicine, but we also do quite a bit more. This is just like a very brief list of things that we focus on every single day. There's more to it. I didn't want to put everything we do because we wouldn't have enough time. But these are all things your gynecologist can also help you with, and I think that that is unknown for women most of the time. A lot of this you go to your primary care doctor for, and they may or may not be able to help with it, but they don't really always know where to steer you. So go see your gynecologist. A few things we do that people don't know about. Urodynamics, you need them. If you have any issues with leaking urine, going to the bathroom frequently, pain, when you go to the bathroom, urgency, having a problem just going, feeling like your bladder's not empty, bladder infections. This is kind of where these type of scenarios kind of bring out the mama grizzly bear midwife in me. I am a midwife by trade, and so we get a little angry when women aren't heard. We tend to get told a lot, if you have kids, if you get older, urinary issues are normal, right? Well, if you've had babies, it's normal to, pee your pants if you cough or laugh. Is it a side effect of trauma to your pelvic floor? Sure. Is it normal to pee your pants the rest of your life? Hard no, it is not. It is fixable. So we really need to kind of change the narrative, both in healthcare and from a patient perspective. Like, don't be okay if somebody belittles that or negates that and says, oh, well, you're 50, and so what? You pee when you sneeze. That's okay, just wear a pad. No thanks, I'm not gonna do that. We have testing. It looks kind of scary. It was hard to find like a good image that didn't look terrifying. But when we do the urine studies to pinpoint the problem areas that we can absolutely improve, these are done in our clinic with our nursing staff, all female, and take maybe 10 minutes. It's not as invasive and traumatic as the picture looks, I promise. Nobody just like pees all over the place during the test. So it sounds kind of terrifying and daunting. It is not. Our team is very aware of the stigmas that come with a lot of things in women's health, and really work hard to make sure you feel comfortable, that you understand what's going on with the procedure, that it's not embarrassing, that it's okay, that it's common, and that you are not crazy, and that you are normal. So don't be intimidated. Try not to feel intimidated about having these discussions. There's no topic that's off limits in our clinic anyway with women's healthcare. To my children's everlasting disappointment, I have zero filter. They're used to that now that they're adults. They were terrified of that when they were teenagers. But when you're trying to help patients, feel better in their bodies, you can't have a filter when talking to patients about stuff. Nothing's embarrassing. We also work on GI problems, which I think most people don't expect from a gynecologist, but we absolutely do, because again, pelvic floor dysfunction is a real thing that happens. Is it normal? No. Is it fixable? Yes. So chronic constipation, bowel incontinence, or leakage, pain, rectal pain, pelvic floor prolapse, things like that. We have testing for that too, same thing. Only takes a few minutes with female staff. They walk you through every step of the way. Nobody poops in the exam room. That doesn't happen during these tests. But again, this is something very fixable, very taboo topic, not something that patients are very comfortable bringing up, not something that's routinely asked. A lot of times when you go to your provider for your annual physical, but is a real problem that we can fix. This is another thing we don't want people to be embarrassed about, be secretive with. We don't want you to have to rely on a variety of feminine hygiene products just to get through your day and constantly, worry about going places and where's a bathroom and what if this happens, when we can work the problem and get a solution for you. Trauma-informed care is really one of my great loves. I'm newer to the Iowa Women's Health Center team. The speakers last night, I kind of felt like the spotlight was like, woo, right on me, which was actually kind of validating for me. So I joined the team very unexpectedly in November after having a career for like 11 years or so with a different clinic. Was not a planned change, kind of just blew me right out of the water, right as I was also turning 50, so also awesome. But I have found my tribe. It was definitely unexpected, unplanned, never in a million years would I have thought as I was going through this unexpected transition, the good that it would do me. But absolutely 100% from a personal perspective, I agree with the speakers last night, find your tribe, because it makes all the difference in the world. And I think, one of our goals at Iowa Women's Health Center is for patients to find their healthcare tribe, and I feel like we provide that across the board to all of our patients. So with trauma-informed care from a clinical perspective, it's important to recognize that people have trauma very often, and it affects people really differently. When you look at statistics, 1 in 5 women have experienced domestic violence, 1 in 4 have experienced sexual assault, 50 to 75% will have long-term PTSD because of that. We also know those statistics aren't entirely accurate because those scenarios are also very underreported. So it's important to recognize when you're taking care of people that there's a real likelihood that there's some sort of trauma for that patient, and we don't want to re-traumatize people. We want them to feel safe. We want them to be comfortable with the plan. You know, when we're talking about things with women's health, a lot of times that involves, you know, pelvic exams, breast exams, things like that. Your provider should be having a conversation with you and about that, about your past experience with exams, your comfortability. If they don't bring it up, advocate for yourself, and I know that's an easy thing to say and a hard thing to do, but you need to be comfortable with those exams. You need to know what to expect, what the exam entails, why we need to do it, what value we're getting from it, and informed consent is a very real thing. We need your permission, and we should be asking for that. So advocate for yourself. I know, I feel like in the world that we're living in today, we need to kind of come together as women especially and really push for some changes in the realm of healthcare for women in general, and trauma-informed care is a big one. Pain and anxiety, another love of mine. Well, to manage it, not to have it. In women's health, I think, you know, I'm not going to have people raise hands or anything like that because, you know, confidentiality also matters. But I know if I asked for a show of hands, if anybody has ever experienced anxiety with procedures or exams or pain, that I would see a pretty big response there. Same thing from a provider perspective. This should be a routine evaluation when you're doing a consultation with a patient. If your provider doesn't bring it up, advocate. There are all kinds of things we can do for these, for both of these scenarios. There's medications we can prescribe and send to your pharmacy for anxiety before you come in for your procedure that day. You know, we can do, you know, little things too, teach you some breathing. We, you know, can have some, you know, sound machines going so you're not in this cold, very quiet room, because that's always kind of awkward when there's, you know, just nothing but silence during procedures. And we can also manage pain pre-procedure, during procedure, and post-procedure. And there's more than one way to do these things. So, you know, when I'm talking to patients about any kind of procedure, I explain the procedure in detail. Hey, this is what this is how we do this. This is why I need to do it. This is about how long it takes. How are you with anxiety with procedures? And then we have that conversation. A lot of times, probably my most common pain trauma is people that have had IUDs put in, and they're thinking about maybe doing another one, right? My next question is going to be, how was that IUD experience for you before? How did that go? Was it very painful? Was it comfortable? And generally, this is when the floodgates open, and people can a lot of times get very emotional talking about it, and it makes me real angry when I hear the trauma that people endured just for birth control, and how terrified they are of having to sort of like power through it again, because that's what they had to do the first time. And I will be very frank with them and tell them I will give you all the things I can give you that you need to make this experience comfortable for you. I want you to not come in here terrified and just powering through like women tend to do. So there's a variety of things that we can do, and I just tailor the plan for the patient. So here's all the things I can do for pain. Here's how they work. Which ones do you want to start with? Also knowing that you can pause at any point in any procedure and readdress that pain and add something if you need to, and then carry on. So, and reminding people throughout the procedure, checking in with them. Are you doing good? Do we need to get the laughing gas? Because we could all use the laughing gas. I think it's, you know, it could be a party in the room, but we don't do that. But just, I think, even knowing that there's ways to manage the pain and discomfort will naturally reduce people's anxiety. But what really throws me when we get into these conversations is the gaps in healthcare for women a lot of times are because they had a really traumatic experience with a prior procedure, like, maybe they had an abnormal pap smear and they had to come back and get a cervical biopsy, and it was so awful and terrifying that they didn't get another pap smear for 15 years. And we don't want that. Screenings matter. Screenings for cancer matter, and we need to make sure people are not so traumatized that they're sacrificing their health because they don't want to be traumatized again. Same thing with adolescence, and I was just talking to one of my partners about this earlier. There's a very old school theory that if you need birth control or anything, a pelvic exam is required. Not true. Very old school medicine. I tell my patients, especially my patients that have teenagers all the time, there's a lot of stuff we can find out from other tests that don't require a pelvic exam. If your daughter wants to come in and talk about birth control or STD checks or anything like that, just have them come in and tell them they get to keep their pants on. We don't require that, especially for our adolescents, because we want them to be comfortable with their care. We want to start them out how we all should have been started out, with comfortable care. Perimenopause and menopause. Yay! I'm right there with you. What are hormones? They are messengers that tell your cells what to do, and they kind of unlock the function of your cells, and they are everywhere. If you go to the interwebs and Google hormone receptors, you will be shocked at all of the places these things live. They're not just ovary uterus type of a thing. They're in your muscles, they're pelvic floor muscles, they're in your shoulders. A lot of women have joint pain in perimenopause. Well, guess what? This is why. A little bit of a history lesson. I was having a hard time with kind of deciding what I wanted to talk about, so I scrapped my whole plan, 3 days ago at like 2:30 in the morning, because why not? And redid some of my information, mostly because of when you're talking about resilience, like I don't know a population that is more resilient than women. So I think it's important that we also, kind of summarize our history, that we're still fighting to not follow us around for the rest of our years. So way back, ancient history, wandering womb theory was a fun one from the Greeks. We can thank them for that. That was a theory that if your womb was not fulfilled with childbearing or taking care of a husband, it wandered around and caused physical ailments and psychological ailments. So the fix for that was, babies and marriage. The hysteria theory kind of branched off of that and was a psychological crisis. So that's awesome. And the treatment for that was marriage, children, and not, being educated. And just staying home and hearth, taking care of the home and hearth. The hysteria theory, shockingly, was still a diagnosis into the 1970s, which is appalling. Average lifespan changes. There's really no menopause data back from the 1800s because we died before we hit menopause. There's a lot on erectile dysfunction from the 1800s and just a little bit of a gender gap there. 1900s, yay, we lived for like a couple years after menopause. So that's kind of where we started to see some of the old school theories of, well, you can treat menopause, but only for 2 years, and then you don't need treatment after that. Well, it's because we died. 1950s, it got a little bit better. We started to live longer, didn't have tons of great health care for menopause, but we'll get there. Today we live to about 80-ish, a little bit longer than men, so way to go us. Menopause pretty steady. 1939 is the earliest known bioidentical, so that's like plant-based hormone therapy that's essentially the clone of the hormones your body makes, so your body doesn't recognize that as a foreign thing, which is good. Briefly was used in 1939 to treat people after they had a hysterectomy. And then it kind of fell by the wayside. Premarin was introduced in the 40s by the FDA, and so that kind of took over and gained some ground. And then the bioidentical pelleting went away for a while. And this also was only for menopause. The perimenopause, we don't get anything. They heavily marketed Premarin, and it was one of the most popular medications prescribed all the way into the 90s until some super awesome people did a Women's Health Initiative trial. It was supposed to last 8 years. It did not. It failed miserably. They were kind of giving the wrong hormones to the wrong people, so they had to stop the study because there was a lot of cancer, heart attacks, strokes. It didn't seem to matter that the study design was so bad that the people that they put in the study were already well into their 60s and 70s and already had health problems and already had heart disease. But because the study was marketed so much, people are still clinging to that in the healthcare world even. They have not repeated the study. They've refuted it several times over, but nobody really is paying attention to that. If you go to conferences today for menopause and things like that as a healthcare provider, they still hang on to this study. And I think that's why a lot of traditional gynecology clinics are very shy when it comes to hormone replacement because of this debunked study. We ignore that study at Iowa Women's Health Center because we know it's inaccurate. So history matters. Medical schools still have not updated their curriculums when it comes to menopause. There's really actually not anything in their curriculum for menopause for the most part. And so providers are still referencing very old data. It's really hard to get traditional gynecologists to understand hormones and treat them. If you get your hormone labs drawn, a lot of times at your annual exam, all that's going to tell you is, hey, congratulations, your hormones say that your ovaries are still kicking out eggs, you're still childbearing, go you. Or, oh, your hormones are depleted, your ovaries are all shriveled up, you're menopausal, so no more babies for you. It's not something that they're using to treat based on your symptoms and things like that. A few symptoms for hormone deficiencies, both perimenopause or premenopause and menopausal, a lot of these things I don't think a lot of people know are related to hormone changes, but remember you've got hundreds and hundreds of hormone receptors all over your body. We do have on the table over there a health assessment that we have people fill out no matter what they come to the clinic for, to kind of help them connect the dots that, oh, maybe I'm not crazy because I have all of this going on. So when we look at that, we are looking at your symptoms, and then if we do a hormone panel, a pretty extensive one. Insurance is not awesome when it comes to women's hormones, so we actually just have a $75 flat fee for a comprehensive panel for hormones, and we're looking at all of these things. In perimenopause, generally people don't need anything other than testosterone because your ovaries are still functioning, and a lot of those symptoms are testosterone based. There's a really sharp decline in testosterone for women. When you hit your 40s, we kind of fall off the testosterone cliff, which wasn't a great thing for Mother Nature to do. Men have this nice sort of gradual decline, and we just go like this. And that's when people tend to notice the symptoms, even sometimes starting in your 30s. The most common and effective testosterone replacement right now is a testosterone pellet that we put under your skin, usually somewhere between 2 to 4 times a year, just depends on the person. We can add estradiol pellets to that as well, but testosterone is not an easy thing to absorb in other fashions, so we tend to lean more into the pellets because it keeps your testosterone more stable. And you don't have to be in menopause for that. few things that testosterone, just a few things that testosterone does. It does have, like, I think Kendra had said age reversal, and it does, because it does help your bone density kind of return. It will reverse some bone loss. Same with brain, heart, and tissue. You have a lot of testosterone receptors in your muscles. It affects your sleep. It affects your brain fog, memory, remembering what you're doing, like, why did I walk into the kitchen? I have no idea, kind of a thing. Just that clarity is all testosterone driven. Sleep disturbances, I'm sure we've all been there, done that. Libido also for both men and women, and just energy. Weight and fat distribution will change also as your testosterone decreases. So sometimes we kind of joke about the menopause middle. It's a real thing. That's not a myth. So increasing testosterone will help with that as well. You'll keep your muscle, and your fat distribution will change so that we aren't all feeling like Santa Claus. Estrogen benefits also. Estrogen surges a lot, especially perimenopause. Your estrogen kind of goes on this roller coaster ride, which is why some days are better than others. It's why people start to get thin, kind of see-through skin. It's why people have hot flashes. It also can affect your risk for dementia. So if your estrogen is declining once you hit menopause and isn't replaced, you're going to be at a higher risk for things like Alzheimer's disease. It also helps with your cholesterol and bone and heart health. Progesterone is kind of the nice hormone in terms of sleep. It can help with hot flashes and night sweats and things too. It's an anti-anxiety hormone, so it does stabilize your mood and can kind of reverse some depression and anxiety symptoms. We use it pretty frequently for anxiety and sleep. It can also help regulate periods. I don't know if anybody's experienced the perimenopause hell of irregular periods and never knowing when you're having a cycle, how bad's this one going to be? How long is this one going to last? We can kind of regulate that a little bit better with progesterone. So when we look at the real big systemic issues, dementia is a biggie. Women get Alzheimer's way more than men do, but a heck of a lot less if you're getting your estrogen replaced. The earlier, the better. The earlier that we can replace your hormones, the more reversal will happen in your body. And when we do hormone replacement with men, that's one of the things that we're also looking at for them is increasing their testosterone and helping them avoid dementia as well. Osteoporosis, that bone loss again, we can reverse some of that the earlier we get people on hormone therapy. Estrogen and testosterone have kind of a synergistic effect. So for some of these things, the improvement will be better with both of the hormones, not just one. But that's, again, where we go into your symptoms, your labs, and we're constantly rechecking those things and adjusting hormone plans based on the patient. Heart disease, especially for women, it gets missed about 50% of the time. If you look at the pain gap in gender, women are 50% less likely to be assessed in an ER for heart attack than men, because apparently we don't have heart attacks when we're women, even though it's well documented. I'm not sure why. Estradiol estrogen replacement will improve that, and testosterone does too. It really strengthens your cardiovascular system. It lowers cholesterol. It makes it harder for cholesterol to kind of stick to your veins. It increases your good cholesterol and things like that. And those are all, things we should be getting checked with our physicals every year, so we know where we're at with cholesterol health. And this can help reverse some of that too. Questions? Nothing super specific. I can't give you medical diagnoses from up here, but does anybody have any questions on all that? I know that was a lot. Yeah.
So the last time I went and had an exam, my doctor was male. I was told, great, things are fine,
shocking. Yeah, not shocked. Not shocked. So in terms of 5 years for routine screenings, when we kind of think back to like traditional medicine and gynecologic care per Google, we all have the same guidelines to follow for screening and preventive health. So we have the CDC, we have the National Institute of Health, American College of Obstetrics and Gynecology, American something of Family Medicine, that have risk stratification guidelines for like cancer screening. So for women over the age of 30 with a normal PAP history, and PAP is for cervical cancer screening, then that PAP recall would be in 5 years. That does not mean that people shouldn't have a physical, either with their gynecologist or if they have a great primary care provider. Somebody should be laying eyes on and hands on you once a year for a head-to-toe check and preventative screenings. You should still be getting mammograms every year after the age of 40. Colon screening starts at age 45. You don't have to see a GI doctor for that. Your gynecologist absolutely can put in the orders for that, should be putting the orders in for that. And just annual screens too. Thyroid, there's not typically a routine thyroid screen we do because we catch a lot of missed thyroid dysfunction because that falls into the realm of hormones. But you shouldn't be getting a 5-year pass other than for that pap smear. Now, for the yearly exam, if somebody's not due for a pap and they don't have any pelvic concerns or complaints when I see them, you can keep your pants on. I'm not going to do, and nobody should be doing routine pelvic exams if there's not a reason or there's not like a family health history that would dictate that. There's not a whole lot of value in doing a pelvic exam if somebody's not having any problems. And you can absolutely decline that if you aren't due for a PAP, don't have any risk factors, and don't have any problems, and have an exam, still have a complete physical without that. And I think that's another kind of old school theory that hasn't transferred over to the medical world, and patients don't know either, and it's not on them to know that invasive exam is not a requirement to have a physical with your provider. Yep. Any other questions? Yeah. Yeah. Not yes and no, not a lot. It's definitely in the world of politics right now, not a, shocking, I know to everybody, not a really high priority. One of the things that I love with our team is we know that this is a huge gap in traditional medicine education, and we all do continuing education. It's a requirement, for us to keep our certifications, but they don't require what you're doing your continuing education in. So we work really hard at finding education that's more on the functional medicine side of things, that's not really governed by the federal guidelines and government. We still stay savvy and up to date with the more traditional things like the PAP screenings and things like that, but we're going out and finding our education in the functional med side of things because we want to be able to integrate that into our practice, but it's not a requirement, and so a lot of clinics just kind of stay in their traditional lane. I think our clinic's kind of a unicorn in that we're combining both, and we're constantly having meetings and sharing information and always looking at what else can we add to our services to promote that more functional side of things, even for things like, Hashimoto's thyroiditis, which is more common in women than it is in men, very underdiagnosed. Not always does it need a medication. There's actually a lot of things that we can change in your diet and supplements, plant-based supplements and things like that to help actually manage the symptoms. And that's all coming from functional medicine training that we're picking up and learning about, and it's changing all the time. And so we have a lot of things in the works that we're looking at to kind of increase our services and try to make our clinic as much of a one-stop kind of shop for women as we can. And I also learn something every day from my patients too. I have like a notebook with lists of like really great resources that patients have found. And, you know, we just get sidetracked talking about things and I'm like, oh, wait, what was that book? Like, where did you find this, you know, supplement information? And patients are like just a fountain of knowledge too. And so we're, you know, kind of always stealing those resources from people too and adding that to our toolkit. Yeah. Yeah.
I have been digging into this a little bit more, researching recently, but I was shocked to find out that they really recommend 8 to 10 years beforehand. Is that true? To kind of really say, you know, to really minimize the bone loss and all that kind of stuff, like leading up to it, so that they're recommending people really, you know, at age 40 to really try and be more proactive on these things. And then also, as far as, it sounds like to me on that, estrogen and whatever, I'm starting to find this out, but it sounds like we should be really looking for more of a mix of estrogen and testosterone kind of thing, and that's what we should ask about when we go in.
Yeah, and the testosterone is really the biggie to start early in perimenopause. And perimenopause, you know, hopefully modern medicine will start recognizing that. That still is just really not even a conversation that they have. But the earlier you start replacing your testosterone, because of the cliff that we fall off of with testosterone when we're in perimenopause, the more reversal that you will have with your bone, brain, heart, skin. With estrogen, we keep an eye on that. And I was going to put kind of a sample patient up there, but then it gets really hard to read. But when we're looking at people's labs, the numbers are only a small part of it. The symptoms are almost a bigger deal. And so when we're calculating out supplementing any of the hormones, it's based on both. It's not a cookie cutter situation at all, like some things are. So it's really, really individualized, and then we adjust it based on the lab changes and how people's symptoms are changing. If you're still kicking out a healthy supply of estrogen, we'll keep an eye on it and keep checking it, but you might not need a testosterone or an estrogen replacement, like a patch or a pellet, but you might need, even if you're kicking out good estrogen, if you're having issues with, you know, pain with sex and vaginal dryness, well, you probably need some vaginal estrogen. So there's a lot of like variation of hormone replacement, but the earlier, absolutely the better. Once you're 10 years post-menopause, we can do hormone replacement, but it's not going to undo all of that previous damage that far down the line. It's going to help, but it's not going to help as much as it would have earlier. Yeah. Yeah.
I want to thank you for doing what you're doing. I'm a patient who is trying to build my functional medicine and my primary medicine together, and for what you're doing is making a difference to how knowledge and understanding of medicine. So thank you.
Yeah, thank you. Thanks. Thank you. Okay. Anybody else? Are we good? Table.